Raquel. Raquel is a faculty assistant professor at Harvard Medical School who has been with MapNet from the beginning. She's an expert in the cognition in psychotic disorders and has done some really important work. And in the last several years, has led the Consumer Advisory Board, as it used to be called. It has a new name now of participatory action involving joining hands between stakeholders and mental health professionals to um, move forward with the cause of improving quality of outcomes in mental health care. And the topic of today's panel, Therapeutic Alliance, is something that she and her group, along with the other panelists today that will be speaking on Therapeutic Alliance, on the central importance of Therapeutic Alliance in outcomes. Thank you, Raquel.
Thanks so much, Kash. And I'm wondering, is it possible to share the slides? I don't know, Kelsey or Ikra might be able to put those up.
Yes, I'll pull that up. Thanks.
Great, thank you. Well, anyway, good afternoon, everyone. My name is Raquel Meshullam-Gately. I am a psychologist and I co-direct now the RISE Early Psychosis program over at Cambridge Health Alliance. And there we provide services to people within their first episode, as well as those at clinical high risk for psychosis. And as Kash mentioned, I also previously had the pleasure of working at Beth Israel Deaconess Medical Center and Massachusetts Mental Health Center for many years, where I was grateful to be involved with MapNet and collaborate with the Peer Advisory Advocacy and Research Council, or PARC, which is a partnership between researchers, clinicians, and people with lived experience conducting participatory action research, as well as advising on clinical services and engaging in mental health advocacy. So with that, I'd like to welcome you all to our panel session today that's focused on Therapeutic Alliance and early psychosis through the expertise of this incredible panel's clinical, research, and lived experience perspectives. And in addition to defining the Therapeutic Alliance and its relevance to early psychosis, our goal is to review how it's experienced, studied, and practiced. We believe that each of those perspectives brings unique insights that together can guide more effective and compassionate care. So before I introduce the panelists and to set the stage, I'd like to briefly comment on how we're defining Therapeutic Alliance for this panel and why we feel like it's such an important topic to address, particularly for people in the early phases of psychosis. And I don't know, oh, there's the slides. Make sure they forward. And if you need me to share the slides, Kelsey, I can try to do that. Okay. If you can pass to the next one, that would be great. Thank you. So the most influential definition and widely accepted framework for Therapeutic Alliance comes from Edward Borden in 1979. And he used the term working alliance to reflect the quality of an active working relationship. And that model, that tripartite model, is the foundation for most alliance theory. And it's been adapted to nearly all therapeutic modalities. So Borden described the alliance as having three parts. So agreement on goals or a shared understanding of what the therapy aims to achieve, consensus on tasks or agreement on how to get there, and then the bond or the trust, respect, and connection that holds it all together. So in other words, working together towards meaningful change in a way that feels safe and respectful, and I'll add in a person-centered, recovery-oriented, and culturally responsive way. Think in the early phases of psychosis where there can be a lot of fear, confusion, and mistrust, and engagement can be really difficult due to stigma, perhaps reduced insight. The Therapeutic Alliance can be especially important. I think it can be the bridge between the individual and the treatment system, and it helps foster safety and collaboration where both may feel most fragile. And additionally, as we'll soon hear about more from the panelists, a strong alliance is critical for supporting better treatment engagement and outcomes. Okay, so without further ado, I'd like to introduce our panelists. And just a note that these are very brief introductions. If I tried to list everybody's accomplishments, we'd be here for a very, very long time. So first, conferences related to his work on the council. He has been working for 10 years with Tomfoolery Music. That's an organization that brings live music to communities that often wouldn't have access to live performances. Tomfoolery is an organization of musicians in mental health recovery who bring music to inpatient units, assisted living facilities, day programs, and other mental health related venues. At Tomfoolery, Nate plays drums, percussion, guitar, and vocals. He works as a concert manager when the gigs need amplification and a studio technician when members want to record their music. Then there is Charles Strohmeyer. He's also a member of the Park, as well as another peer research group at Beth Israel, and he has co-authored several papers in academic journals and presented at conferences. He has over 30 years of experience with investing and 20 years of experience with artificial intelligence innovation and with mentoring startups. With a passion for making a lasting impact, Charles has mentored many different kinds of successful and award-winning startup companies. And as a result of all his efforts, Charles was a recipient of the 2019 Deval Patrick Commonwealth Innovation Award. Then there is Dr. Kim Muser. He is a professor of occupational therapy and psychological and brain sciences and senior researcher at the Center for Psychiatric Rehabilitation at Boston University. His research interests are on the development and evaluation of psychosocial interventions for serious mental illness. He co-led the team that developed and evaluated the Navigate treatment program for first episode psychosis in a rigorous cluster randomized controlled trial in the RAISE ETP project. He has published over 400 articles, 20 books, and 100 book chapters. His most recent books are Social Skills Training for Schizophrenia, a step-by-step guide, and Treatment of Post-Traumatic Stress Disorder and Serious Mental Illness, the Cognitive Restructuring Program. And finally, Dr. Julia Brown is a clinical psychologist and the research director of the Wellness and Recovery After Psychosis program at Boston Medical Center and Boston University School of Medicine. She has conducted numerous studies on the Therapeutic Alliance and treatment for people with schizophrenia and other psychotic conditions, including empirical work and systematic reviews and meta-analyses. In one of her studies, she rated the Therapeutic Alliance in the RAISE ETP trial for first episode psychosis from therapy audio tapes and showed that the strength of the alliance predicted 2-year outcomes. Additionally, she provides workshops, presentations, and consultation to clinicians on how to develop and maintain a strong alliance when delivering care to those with early psychosis. So with that, I am going to pass the baton to Dr. Brown to address the research perspective of Therapeutic Alliance further, including what current evidence tells us about the impact of the Therapeutic Alliance on engagement and outcomes in early psychosis, as well as findings about important components and predictors of Therapeutic Alliance. Julia, take it away.
Thank you, Raquel, and thanks everybody for inviting me. I I am going to just provide a very brief overview of what we know about the Therapeutic Alliance from a research perspective. So I think Kelsey's controlling the slides. If you could advance one slide. Thank you. So the Therapeutic Alliance is one of the most widely studied therapy process factors in the general population. There's been hundreds and hundreds of studies looking at the relationship between the Therapeutic Alliance and outcomes. And across these hundreds and hundreds of studies, it's very clear that there's a strong relationship between a high quality therapeutic alliance and improved treatment engagement, reduced dropout, and better clinical outcomes. This relationship is so strong that it remains unchanged by a number of different characteristics that we might expect actually do make an impact. For example, the type of treatment that's provided doesn't change the strength. It is still important in a psychodynamic treatment versus a CBT treatment. It doesn't change the type of outcome. You can look at a sort of general quality of life outcome or a more symptom-specific outcome. The alliance still predicts outcomes. And similarly, thinking just about the alliance can be rated from the client perspective, the therapist perspective, or an independent observer. And regardless of who is rating the alliance, it still predicts outcomes. And finally, whether you rate the alliance early in treatment, in the middle of treatment, or at the end, it still is associated with improved outcomes. So really what this is telling us in sort of the general psychotherapy literature is that this relationship is so strong, you can throw anything at it, but it still remains very strong. Can advance to the next slide. So what do we see when we look at alliance in psychosis treatment? And you'll see that it's the same. It matters just as much when providing care for folks with psychosis and schizophrenia. A strong therapeutic alliance helps people stay in treatment longer, reduces their likelihood of dropout, and is associated with better clinical and functional outcomes. Compared to the general psychotherapy literature that I just talked about, which has hundreds and hundreds and hundreds of studies, the Therapeutic Alliance work in our field is smaller. One of the reviews we did found 84 studies, and that is continuing to grow. But of those, that sort of small but growing literature base, the Therapeutic Alliance is really strong. And Raquel mentioned in my introduction that with the help of Kim on this panel and many others who were key in the RAISE ETP trial, we were able to measure Therapeutic Alliance at session 3 for people who received the individual resiliency training component, the individual therapy component of Navigate, and found that a strong alliance at session 3 predicted improvements in 2-year outcomes across pretty much all the outcomes that we looked at in RAISE. So people who had a strong alliance at session 3 had greater improvements in quality of life, symptoms, mental health recovery, and psychological well-being, really highlighting that the Therapeutic Alliance matters when we're providing care in early psychosis. Can advance to the next slide. I want to highlight one really important study that looked at alliance in early psychosis. And really the takeaway from this is that a strong alliance isn't a nice to have, it's really a need to have. This was a study of about 300 individuals who were receiving psychotherapy for early psychosis. And what this study showed, if you look across in green, is that when you have a strong therapeutic alliance and people continue to attend therapy, people have an improvement in their symptoms. We would expect that to happen. But what you see in red is really the main contribution here of this study, that if you have a weak therapeutic alliance, but people continue to attend, and we can imagine there might be many reasons why somebody continues to attend even though there's a weak alliance, that actually leads to a worsening of symptoms. So it's not just that alliance helps improve, but if you're continuing to be exposed to a poor or a weak alliance, it can actually be harmful to the people that we're serving. So this is a huge message here that the alliance really matters when we're delivering care and should be considered really a core element of the treatment that we're providing. Next slide. And the last one. So overall, what we know from a research perspective is that it is possible to develop a strong alliance very quickly by session 3. That when we have that strong alliance early on in treatment, it predicts better treatment engagement, and it also can lead to functional and symptomatic improvements up to 2 years later. So I hope that with this very brief introduction and this message, that our panel is able to elevate the importance of the Alliance in early psychosis care. I will pass the baton back to Raquel.
Thanks so much, Julia, for sharing that research perspective. And I'm wondering now, since we're addressing research, Nate and Charles, if you might be able to briefly summarize our PARC project on the association between Therapeutic Alliance and quality of life. And Nate, I'm going to ask you to start, just since you were involved in the project a little longer than Charles. Go ahead.
Yeah, so we did a study to look at the relationship of Therapeutic Alliance to quality of life for people with serious mental health conditions. And what we did, we reviewed several studies that studied Therapeutic Alliance, and we looked at their questionnaires. And among our group, we looked at those questions and we selected questions that we felt were more important to us, and the questions that were more important to us were kept, and the questions that were not as important, we let them go. And then for the outcome, we modified an existing measure called the WHO-QoL, which is a quality of life measure. And so we looked at those two questionnaires, and we did the study. We had about 76 people, I think, selected because of we needed 69 for statistical significance, I think it was. And so we got 76 people, and we found that there was an association between Therapeutic Alliance and quality of life. It was a little bit, for what to compare the Therapeutic Alliance to, we felt that quality of life was a good measure to try to correlate with Therapeutic Alliance. For some of us, at least, more so than symptom reduction. And a few reasons for that include that the side effects of medications can be very difficult. And so someone taking these medications, they might have reduced symptoms, but at the same time, due to their suffering from, their quality of life might not be as good. We felt that quality of life was a good measure, and possibly something that we'd rather look at than symptom reduction. I guess I'll pass that on.
Great. Yeah, thanks so much, Nate. And I'll just add, this is the first study to look at the association between Therapeutic Alliance and quality of life using a participatory action research framework. I just wanted to add that important part of it. And Charles, is there anything that you wanted to add about the project?
Well, I don't remember if our project looked at this. Maybe Julia would know. Does a strong Therapeutic Alliance for people with psychosis help improve social functioning? Because that's a key to quality of life.
Yeah, that was one component of quality of life that we looked at, and it seemed like there was a strong association between the Therapeutic Alliance and all aspects of quality of life, whether it be relationships, work, just any other things that we rated within the area of quality of life were deemed to be kind of strong predictors. Anything else, Charles, that you wanted to add on that?
Not right now.
Okay, great. Well, I'm going to turn to the clinical perspective now, and was wondering, Dr. Muser, if you might be able to comment on that further, specifically about developing and maintaining a strong therapeutic alliance and working with people in the early stages of psychosis, and anything else that you might want to add about that.
Great. I'd be happy to. Thank you, Raquel. Using the framework that Raquel introduced earlier today about the therapeutic alliance being comprised of agreement on goals, agreement on tasks, and interpersonal bond, I'm going to break out some basic clinical strategies for trying to develop a good working relationship or therapeutic alliance. First of all, to start talking about agreement on goals, the primary question here is to begin exploring what kind of changes would the person like to occur as a result of participating in treatment. It's important to remember that many people don't enter treatment, especially people with the first episode of psychosis, with specific goals in mind. And so, bearing that in mind, you want to avoid overusing the word goals early on in treatment. Instead, explore the person's life with the person, including things that they're satisfied with, that they like, and things that they're dissatisfied and don't like. Consider the areas of dissatisfaction to be possible areas of goals that you might work together with a person on. Bring them up, talk about how you might work together on them, and see if they're interested in collaborating on that. And at that point, you have goals, shared goals to work towards. When identifying goals, it's important to identify some goals that are functional in nature, such as improving work or school functioning, such as getting a job or going to school or improving one's performance in either of those, developing or improving the quality of relationships or leisure time, improving somebody's independence or living situation, and the like. And to not only work towards goals that are focused just on symptoms or negative feelings. And the reason why you want to have some functional goals to work on is often they're even more important to people's lives than are the symptoms and the feeling states that they may have. And second of all, we actually know much more about how to help people achieve these kinds of functional goals, or we're much more effective than we are at making negative feelings go away and symptoms go away, although we can improve coping. When people are extremely distressed, like feeling very depressed or very anxious, one way to get at an underlying goal is to find out if you didn't have all of these problems related to depression right now, what would you be doing that you're not doing? It's not like you're not going to help them deal with depression or other symptoms. You will, but you want it to be in the service of a greater goal. The next part of the working alliance is agreement on tasks. And so it's important to explain how you work. If you're using a CBT approach, to explain how you'll develop home assignments together and you'll review them. You'll talk about the agenda, what you're hoping to accomplish at each meeting, and the person can have input into that. You'll teach a number of different skills that can be used to help the person make progress towards their goals, and so on and so forth. It may be helpful to have an orientation to a particular intervention at the beginning of treatment. In many of our treatment programs, we have an orientation session, whether it's a family program or an individual program, and we lay out how the intervention works, and we explain how it works, and we also talk about different responsibilities. Hey, here's what I'm going to be doing as the clinician, as the therapist, or whatever, when we're working together. Here's what I'm going to be expecting you to do. Does that make sense? Do you want to make any modifications? And so on and so forth. So that you try to be straightforward in terms of talking about the tasks of therapy, as well as how those tasks are, of course, related to helping the person achieve their goals. And then when you're working together, check in regularly with the person, not just about their progress towards goals. That's important, of course, but how the experience of working together is. You could end every session with a brief discussion of that, or end occasional sessions. But we know that when clinicians get feedback during sessions from people and integrate it into subsequent sessions, that actually improves retention and satisfaction for the participants. And last, let's talk about a few strategies for strengthening the interpersonal bond. First of all, I want to say that if you do a really good job in setting goals and arranging the tasks, a lot of the bond comes along with that because you're really helping the person make important changes in their life. But there are important things that you can also do to further strengthen the bonds. First of all, you can always show concern for the person's welfare and well-being, and of course, show that repeatedly. Second of all, it's important. Sorry. Second of all, it's important to sorry, my phone. It's important to develop a genuine interest. All right. Okay. It's important to develop a genuine interest in the other person, in the client, not just as a client, but as a person. And that means exploring interests that they have, hobbies that they have, special skills or talents, and things like that. When you find something, follow it up and try to learn more about it. Ask the person to share it with you so you can learn more and show interest and enthusiasm in particular areas of expertise or interest that they have. And a last thing is that it's important to try to share something about yourself and to try to make the therapeutic relationship go at least a little bit beyond just a therapeutic relationship to a genuine interpersonal relationship in which there is some degree of give and take, some aspect of reciprocity. And so that can involve telling something about yourself, I mean, as appropriate, of course, sharing certain interests that you may have. You may find that there are shared interests and things like that. And in that way, become a real person, not just a clinician to the person you're working with. And that yet becomes another way of strengthening that bond. Thank you.
Thanks so much, Kim. Now that was a really helpful overview of just different important components of therapeutic alliance that we should keep in mind when we're working with the people that we serve. So I want to shift now to the lived experience perspective, and I'm going to hand it over to Charles and Nate to see if you can share a little bit more about what you think makes a good therapeutic alliance, or what the most important components of therapeutic alliance were when you first engaged with early psychosis care, as well as what recommendations you might give to clinicians for establishing and maintaining therapeutic alliance. So Charles, I'm going to ask you to begin.
Okay. When I first sought help, I was in an outpatient psychiatry setting, and I sought help for obsessive compulsive symptoms and severe suicidal depression. But at that time, neither the psychiatrist or I knew that I had psychosis. And this raises an important point, which is you can go on to develop a good therapeutic alliance, even if the patient has no real insight into psychosis at first. Because I didn't know anything about psychosis, but over time, by being honest with him and vice versa, it emerged that I was having unwanted intrusive thoughts and other functional problems that would persist even in the absence of any mood changes, like problems with formal thought disorder, etc. And so gradually I tried an antipsychotic, and that didn't seem to do anything. It was Risperdal at the time, and it might have been the dosage level. So I quit taking it. But then eventually I was hospitalized. And then after that, I started seeing a new psychiatrist, and that's when I was diagnosed with psychosis more formally. And one thing that helped, another thing is that we would explore cognitive biases that I would have. There's 5 main kinds of cognitive biases, and mine were related to false beliefs and overly negative thinking. And what I found interesting, by the way, is last October in the journal Schizophrenia Research, there was a paper by Paulina Bagrowska and Cameron Carter and Barnaby Nelson and others. And they found that looking at people who are ultra high risk for psychosis, that the beneficial effects from the therapeutic alliance were mediated by a reduction in cognitive biases. And I think this is very important for clinicians to know, because young people who are having their first psychosis or shortly after may not be aware of their cognitive biases. And also because unfortunately they're starting to confide in AI chatbots. And recent research has shown that AI chatbots systematically violate mental health ethics standards. Like, in a common example would be false empathy. For example, it'll say, I understand or I know what you're going through, and of course an AI chatbot doesn't. And it can reinforce delusions and cognitive biases without even being aware of what it's doing. And I have a forthcoming paper that got accepted for publication evaluating AI chatbots in a mental health setting. So this isn't something I'm interested in. Yeah, so I would say with clinicians, explore the risk of cognitive distortion or biases in young people.
Thank you so much, Charles. That was really helpful, particularly in talking about cognitive biases, and bringing up the point that even if you might not know that much about psychosis in the beginning, that doesn't interfere with development of a strong therapeutic alliance. And also AI chatbots, that's we can have a whole other session about that, but really glad you brought that up, and congrats on the publication as well. Nate, I want to turn it over to
Yeah.
you now to share your thoughts about this.
Sure. Yeah. Particularly early on, I struggled a lot with side effects from medications. When I first wound up seeing someone for mental health, I was okay with trying the medication, and then had some very difficult side effects and wound up stopping taking it. And I failed at that several times, and due to side effects. So to me, a very important thing for Therapeutic Alliance was working with someone who was responsive to those difficulties. And so someone who was, saying, okay, so what are the side effects you're having? And then trying to find a new medication that would have fewer of those side effects. And then adding to that, unfortunately, with these medications, with antipsychotics, for me, any of them do cause some side effects. And so even finding the medication that was causing the fewest side effects, I still had some. And then there was a process of adding other medications to try to deal with those side effects. So adding antidepressants, some anti-anxiety meds, things like that. It is a long process, and it was very important to have someone who was responsive and was really trying to help minimize the side effects and deal with the side effects that I was having. I guess therapy, one thing that was said earlier that I liked was working on some things that are not necessarily symptoms. I was at first very, and probably, still to some extent at least, sensitive about that I have this problem, and I guess to think about other things and to have other things going on was important for me. Yeah.
Thanks, Nate, for bringing up the point of just like moving beyond the symptoms, having that just be the sole focus. And I think that's a big reason why we wanted to work on that quality of life project to begin with. And when you mentioned that it was important for the clinician to be responsive to the difficulties you were having with side effects, can you elaborate more like on in what ways did they show they were responsive?
Well, all right. This is a little bit in contrast to an inpatient unit where, I have had experiences in inpatient units where, and some of this may have needed to happen for me to have the perspective that I do need medication. But in that setting, I definitely have had clinicians who, were kind of saying, no, like this is a medication, you're taking this medication, like not really very considerate of my um, voicing the fact that I didn't want to take the medication because of the side effects that they were causing me. And like I said, I did need some medication. So, I mean, this might be more for clinicians after the inpatient units, like when getting out. But, you know, someone who is not saying like, well, no, this is the medication and you're going to take it. You know, so having someone who's saying, okay, you're having side effects. What side effects are you dealing with? Like, you know, one that I've experienced sometimes akathisia, and I don't think I'd be able to maintain taking a medication that was really causing me that discomfort. So, you know, someone is saying, okay, yeah, akathisia, we'll try reducing the medication, or if that's not working, we'll try a different medication that's less likely to cause that. So that might be a medication that doesn't block dopamine as intensely for a side effect like that. And that seems to be, for me, the medications that I have had less difficulty with, still had difficulty with, but medications that I've had less difficulty with were ones that did not block dopamine as intensely. They have contributed to decreases in motivation and ability to enjoy things. Yeah, again, and just feeling very strange and maybe kind of zombie-like. So, you know, someone understanding like, okay, you're having these things, and what can we do to try to minimize things? So trying a new medication, and then possibly adding other medications to deal with, you know, for me, antidepressants, you know, after trying to get on the medication that caused the fewest problems, then, you know, is still having problems. So then getting prescribed like antidepressants to try to deal with some of that. So.
Yeah. Thank you, Nate, for elaborating on that more. I mean, it's so important to work with someone who's not going to minimize the concerns you're sharing, take them seriously,
Yeah.
explore other options, things that you value, and
Yes.
it's important to you. I'm mindful of the time, and I want to make sure we leave some room for everybody's questions, reflections, and ideas about everything we spoke about today. And I did see there were some comments in the chat, and I don't know, Heather, if you're still here, do you want to unmute yourself and just ask the question on your own?
Yeah, sure. I'm still here.
Okay.
I was just reacting to Dr. Brown's presentation about some of the interesting findings about how exposure to weak or poor alliances can actually be harmful for outcomes. And then just thinking about how it might be important for us to measure, maybe more formally or informally, by having conversations with clients, the alliance, so that way we know when we're exposing clients to weak alliances. And just wondering if there's any thoughts about how we might build infrastructure or make that a more common practice in our field.
I can respond. That is a great question. I think there are a number of different ways. You alluded to both informal and formal. With respect to formal ways, there are a number of widely used therapeutic alliance scales. Probably the most widely used is the Working Alliance Inventory. There are some shorter versions that are widely used that can be integrated into therapy. There's a client version, a therapist version, and an observer version. So I think the most straightforward might be having both therapist and client complete those and discussing the results together. I think more informally, consistently talking through what the goals are of therapy and or whatever treatment we're talking about. I'll use therapy as the example as a psychologist. And then also consistently talking about why are we doing the things in therapy? They are designed to try to help achieve the goals that we've set on, and consistently checking in that your understanding is matching what the client also experiences. And if they don't, that should be really the focus of therapy until there is agreement before proceeding on.
Thanks, Julia, for adding that. Heather, did that answer your question? Any other comments on that?
No, thanks. Thanks, Julia. Appreciate it.
Great. Drew, I'm wondering if you can unmute yourself to ask your very important question.
Sure. Thank you so much for this talk. I really loved hearing all their perspectives shared here. And I wanted to ask all of you here from your different roles, like what recommendations you would have for like altering or augmenting IRT and other therapies for psychosis in order to incorporate an explicit focus on therapeutic interventions that are geared towards cultivating therapeutic alliance.
Great question, Drew. And I know you brought up IRT as well. So I don't know if Kim and Julia, you want to start by answering this. And I'm thinking specifically about IRT as well, how much we can make sure to really focus on therapeutic alliance within the model of IRT at the beginning.
Well, let me just give a couple of thoughts. Julie may have some as well. I think part of IRT is designed to harness or develop a good working alliance in terms of the very specific strategies for helping people develop personal goals. We've actually shown in a paper led by Dan Fulford that the number of sessions you spend on kind of assessment and identification of goals is actually related to better retention over time in treatment and greater improvements. And so as well as the kind of the orientation, the teaching people about how IRT works. But then having said all that, I think it would be really useful to begin to routinely assess the working alliance in IRT and to incorporate at least brief feedback sessions at the end of IRT sessions designed to get the client's experience with the participation in the session, finding out whether it meets their expectations or not, and when not, making plans in terms of making modifications to make them more effective. Even though IRT is designed to be as transparent and open as possible, this kind of discussion about the process of therapy doesn't often take place. It can be very beneficial. There's good research evidence showing that. Last comment is that, and I really thank the person for their question. I certainly think that there may be situations in which there are difficulties with the alliance. It's not as high as expected for any of a variety of reasons. And it's really important for the IRT clinician to be able to step back and to focus really on the relationship, the interpersonal relationship. There's obviously therapeutic aspects to it, but to try to get a little bit more personal, to try to make it more of a connection with the individual, with the notion that a human connection is always at the bottom. It's the core feature of the therapeutic relationship, and if it's not there, no matter what you do, it's going to be much more difficult for the person to really benefit from it. And I think that IRT and any of the interventions for first episode psychosis could benefit from a set of different strategies that are really aimed at enhancing the relationship itself above and beyond the therapeutic relationship, with the notion that the bond is something critical and that sometimes needs primary attention.
Thanks so much, Kim. Julia, is there anything you wanted to add about that?
it's hard to add anything after Kim, but I will add one additional piece, I think, for folks who are familiar with IRT. I think one piece that can sometimes happen is that when you have a manualized treatment like IRT that is, 800 pages long, and it sometimes can be really difficult to implement these manualized treatments, that I think sometimes what can happen as a clinician is that we can proceed on with the treatment because that's the order in which it's there, and we lose the connection between what the treatment we're providing and how it's related to goals. So I think to enhance the alliance, it's always important to think through, here's what I'm thinking that we're gonna plan today in session, and I'm thinking of this because of the goal that we talked about, and consistently connecting the treatment tasks to goals, I think is where I think there's always more room to be able to enhance the alliance in a treatment like IRT and other evidence-based treatments.
Thanks so much, Julia. And I think also like periodically assessing the therapeutic alliance throughout the course of your work with that person is really important too. And actually in the project we talked about before with the park, we developed our own therapeutic alliance scale because we felt that the measures out there weren't really sufficient for capturing what's most important to a person who has psychosis in terms of therapeutic alliance. So I just wanted to comment on that too. And wondering if we could just close it out with one more question I see from Vera. Do you want to unmute yourself for your question?
Yeah, absolutely. So my question is, does racial and or cultural match between client and consumer affect the ability to form alliance or correlate with therapeutic alliance in any way? And by extension, does our primarily white, socioeconomically privileged industry inherently make marginalized consumers exist at a disadvantage in the effort for them to build robust therapeutic alliance?
Thanks so much for asking that, Vera. That is a really important question, or two questions. Julie, I'm wondering if you might be able to just briefly address that from a research perspective, if there's anything that you've seen just in terms of the research on that question.
I think it's a really important question, and one that I don't think has been well studied, particularly not in early psychosis. What research has been done that I'm aware of is that much of the work has shown a strong preference for clients who want to have a therapist that matches them in certain identity characteristics. Much of the work has focused on racial matching. So there is a high preference, but when looking at relationship between alliance and outcomes, they have not shown differences in outcomes, whether people had a racial matched therapist or not. That said, I think the overall research literature is small in this area and can continue to grow. And again, I don't think this has been studied in our population. And so I think it's a really important question and one that largely remains open.
Yeah, completely agree. And I think there's so much to think about with that, just in terms of what qualities in a therapist are most important to the person being served. There could be, racial and ethnic characteristics and other characteristics that are really important as well to look at. So again, thank you, Vera, for bringing that up. And I think it's something we do need to study more and explore. All right, I'm realizing we're probably well over at this point, but I want to thank the panelists so much for teaching and inspiring us with your expertise and experience and all the passion for the work that you do. And thanks to all of you for your wonderful questions and comments as well.
Thank you.
Thanks.
So thank you, Raquel. So that brings me to the most, meaningful part of my own contribution, which is the last few words. The task that I have given myself over the several meetings we have had of this nature over the years is to summarize in a brief way what have we learned in the last couple of days, and especially today, um, that as take-home messages. So it was a very insightful day. We started off with a panel session with Eric Chen and Dr. Nordendraft and Dr. Dostonga to ask the question, why is it that outcomes, early benefits with early intervention do not sustain consistently in the longer run, even though some benefits might persist? An intriguing observation that Eric Chen made is that in his long-term follow-up, those who discontinued the treatment early in that RCT did worse than those who were asked to maintain treatment for the first couple of years. So it's really telling us something, that maintenance is important. How long, how many years, we still do not know. But at least until we have a stable phase of the illness, to me it appears that not only is it's important to comprehensively treat the first episode of psychosis, but it also should be extremely important for us to prevent that second episode that is such a critical piece. Eric Chan also pointed out that it may be that the brain gets hypersensitized to the psychosis experience and might lead to some kind of an maladaptive neuroplasticity, which increases the risk for recurrences. So early interventions should not just be the elements that we have, so far been including in the so-called coordinated specialty care programs, but also other approaches, including exercise, anti-stigma approaches, and peer support services, and so on. And also cycles of learning health systems that we and several others have been doing across the nation are very, very important. Moving on to the next part of the day, we had a really visionary talk by Bob Heinsohn, a leader in the area of early intervention psychosis in this country and abroad. He gave several examples of how important it is to have this bidirectional interaction between science and practice. And he showed how in the last 10, 15 years, the field of early intervention in psychosis has expanded dramatically to around 400 such services around the country. And his optimistic prediction is perhaps by 2035, we would have over 1,000 and so on. I'm an optimist like him as well, even though he tempered that by pointing out that in this current day and age, it's important to focus on valuing resilience as opposed to simply rely on our optimism. And he gave the metaphor of how we have to in this current day and age focus on the approach to kind of absorb whatever challenges that the systems throw towards us, but also be nimble and adapt and focus on what can be done while we are, dealing with the current situations that we could not anticipate or deal with. With the next, and he left with the note, an important note, that the world has changed, and of course will always continue to change, but our mission has not changed, and it should not change. So there was a panel discussion on harm reduction led by Vera, Locke, Jill, and Lionel and Riot, which was really very instructive for clinicians like myself to keep in mind that what is central to our care should be a compassionate, pragmatic approach, focusing on safety while at the same time respecting dignity and autonomy among the people who we serve. So it's not the perfection That's important, but it is the harmony and quality of life. And abstinence may not be the goal for everyone, but harm reduction should be a goal. And finally, there was a wonderful panel led by Raquel on Therapeutic Alliance, where she began with this tripartite definition of what constitutes Therapeutic Alliance, which is a combination of the right goals and the right actions and a trust or bond between the provider and the person who receives the care. And Julia Brown reviewed the literature and pointed out a very important point that not only is it important to have good therapeutic alliance for better outcomes, but bad therapeutic alliance can actually harm. So that's an important thing that we often forget. Kim Muser had some really wonderful clinical insights. The key goals should be to align our goals and our tasks together. And at the same time, it's important to build trust. And how does one build trust? And the key principles there are having a genuine interest in the other person, respect, even some self-disclosure as might be valuable. And Nate and Charles brought out the lived experience perspective and pointed out how it is important that an honest communication in a safe corridor of a therapeutic relationship can allow discussion of problems like side effects and constructively solve them. And that can only improve the therapeutic relationships. Charles also pointed out that the important outcome of good therapeutic alliance is the reduction of cognitive biases. And he also brought out the importance of something that is going to be more and more relevant in the world, which is how AI might impact all that we do. AI can be harmful because if a therapist agrees to everything that happens in an encounter, that could have the problem of reinforcing the delusions. And this is what sometimes AI therapists can do. So in an open, honest and respectful communication, some level of reality check that a human therapist can do is often lost in these AI therapists. This is a topic of great importance. Perhaps an entire day might need to be devoted on something like this. And finally, the important thing that came out through a number of talks today and yesterday, and from some abstracts, is that we need to not only align our goals with what the patient says and what we believe are the goals, but we need to make sure that the goals are the same between the patients and us. So, reducing the voices may not be the goal that the patient has, but improving functionality might be the most important goal. And clearly, data are repeatedly showing that it is the improvement in functionality that predicts outcomes better than simply symptom reduction. So these are many, many important lessons that we learned from yesterday, and we continue to learn. And we always look forward to these meetings annually. And thank you all for your participation. I also would like to thank all of us, all of those who contributed to this successful 2 days, including Kelsey, Ikra, Michelle, Takaya, of course, Margaret Geyer, and several others that have contributed to the organization of these 2 days, and also our ASL interpreters, Patrick, Liz, Erika, and all of you for your participation and your astute questions, and the panelists for their really wonderful presentations and answering these questions. Thanks, everyone. Have a good rest of the day and week, and see you next year.